Want to hear a more diverse perspective on art? Tune in to Speaking of Art, the official podcast of Sharjah Art Foundation, featuring conversations with some of the most prominent artists and curators from Asia, Africa, and around the world. Listen to Speaking of Art wherever you get your podcasts.
That's right, you got the best of the dials, 99.7 FM right now. Ultimate Health on Joy 99.7 FM with me, Notate by Nature. Ooh, a little over 2 weeks ago, 25th of May, 2023, we had the news that a 39-year-old sergeant of the Ghana Police Service, I believe Sergeant Sylvester Boachi, had undergone successful brain surgery with the qualification or distinction that it was awake brain surgery or awake craniotomy. I've been able to reassemble the multidisciplinary team from the Greater Accra Regional Hospital. On Zoom, I have Professor Samuel Kaba Akoria, consultant neurosurgeon. He's also the Director of Institutional Care at the Ghana Health Service. I also have Dr. Emmanuel Yao Vuado, also a neurosurgeon, consultant neurosurgeon with the Greater Accra Regional Hospital. Dr. Jerry Agudogo is a consultant anesthesiologist or anesthetist with the Greater Accra Regional Hospital. And in the studio with me, an old friend, and Mensa Kufuor is a principal clinical psychologist with the Greater Accra Regional Hospital. We're talking about the awake brain surgery. Many of you may have heard that it's the first in Ghana and the first in the sub-region. We'll make some distinctions and clarifications to that. And like I said, I have Prof himself, the lead consultant online with me. Prof, good afternoon. Can you hear me? Hello, Prof. Kaba.
Yeah, good afternoon. Can you hear me, please?
Yes, I can hear you now, Prof. And we're most grateful for reassembling the team and giving us access to your multidisciplinary team this afternoon. You're most welcome, all of you. I believe all of you can hear me. Dr. Vuado, also a neurosurgeon, and Dr. Jerry Agudogo. And I have your sweet lady, Anne, in the studio. Can you all hear me, please?
Yes, I can.
Okay.
Yes, we can all hear you.
Oh, great. Great to have you. Let me start with you, Prof. Akoria, and I hope I'm pronouncing it right. You're an associate professor of neurosurgery. You're at the Greater Accra Regional Hospital. Now, I've had some discussions with you prior to this, but we know there's been awake craniotomy done in Ghana before. I think around 2011. Can you just clarify and then we'll make the distinctions about this particular one you just done in May?
All right. Thank you so very much to you and your listeners. And I would rather start by acknowledging my team and the team that works within the Greater Accra Regional Hospital, the nurses, Dr. Rita, her team, the focus orthopedic team, that has the neurophysiologists who help us to do the brain stimulation and mapping,
right,
and all the people online today, and everyone who helped make this a success. We want to actually acknowledge everyone because this is a multidisciplinary teamwork, as you said. Even some of the people were online and they were in the US and they were online with us to look at the brain map and all that. So it is important to acknowledge that. Now, with that said, and to start and let you really understand, because the word awake surgery tends to confuse a lot of people, even in the medical field.
Right.
Believing that the patient is awake, this is then. But the truth about it is that awake surgery did not start today. Way back before even anesthesia was discovered, surgeons used to operate on people without any anesthesia, and you can imagine how painful that is. And because of that, areas like the brain and the heart and the abdomen were not areas that people tempered with because people bled to death. Then came in the 17th century. I want Ghanaians and your listeners that I do respect a lot, and I want to send my greetings to them as well to really understand this.
Right.
Way back in the 17th century, awake surgery was introduced in neurosurgery to remove epileptic foci and all that. And at the time, they made aim, and a little before that, they discovered in the 1840s, right? When they did awake surgery was to do some trepanation, make a hole in the skull,
That's
and so
right.
the spirit or the air, the bad spirit will go out of the people because of epilepsy and all that.
That's right.
So
Trepanning.
when it came in to really help deal with brain tumor, the first with epilepsy, and it was used at the time. The whole idea at the time was that, okay, you keep the patient awake, you do your surgery, you remove the tumor, and we see how the patient goes. But that credit is not to the neurosurgeon. That credit is to the anesthesiologist who got that, keeping the patient awake for you.
Right.
Then we move from the 17th century, and then in 1909, to be very, very specific, 1909, a German anatomist, pathologist came up. He's called Brodmann, and did the first brain mapping. And I'm telling you a story of over 140 years ago. He introduced what was brain mapping, and that brain mapping helped do awake surgery sufficiently to say that, okay, the tumor is located in this area, in this area. When we do the mapping, this area is responsible for laughing, this is responsible for singing. In our case, if you see, we gave the patient a mouth and we made sing simply because it was located in area 40 and 39, which we call the angular gyrus and then the supramarginal gyrus. Those were the areas that the brain was located at. And those areas help us to be able to coordinate, visualize, and sing. If you watch the video again, you see there was a point where I touched a place and the patient could not recognize. And that is 140 years ago when it was introduced. That made a change in awake surgery.
Great.
So for awake surgery, we need to differentiate it into two parts. The part that the anesthetist put the patient.
Joy 99.7 FM.
Right. It seems we've lost Professor Akoria. We're doing a deep discussion.
I think I lost you.
Right. Please go ahead. You were breaking it into two parts, giving us the antecedents and then breaking it into two parts. Thank you.
Also, in awake surgery, we break it into two parts. The part that the anesthetist or anesthesiology team keeps you awake, and then the part that the neurosurgeon does his work. Then we have a subsidiary part where you have clinical. I must emphasize on this because in Ghana, people have clinical psychologists have no place in theater. And you saw in our case where they evaluated the patient, they gave the best of advice to the family and to the patient, and they were right in the theater. And then you have the neurologists, you have all kinds of people coming in to make sure that this works well. Now, the neurosurgical part.
Joy 99.7 FM.
Okay, my producer will establish or re-establish contact with Prof. Akoria. We're talking about the surgery.
Prof, I have no reason. I don't know why I keep breaking.
Yes, Prof. Just hold. Hold on a sec, Prof. So if you've just joined us, it's about 18 minutes past the hour of 2 on Joy 99.7 FM. We're having a very important discussion about the brain surgery that was conducted on the 25th of May at the Greater Accra Regional Hospital. We, should I say, have valuable access to the members or some members of the team. It's not exclusive, or it's not, should I say, the full team. And we're trying to understand what was done, its significance for training, capacity building in our part of the world, its significance when it comes to access to advanced healthcare and technologies in our parts of the world. If you have any questions, concerned, join us on WhatsApp 055 11 11 997. We're live on Facebook and YouTube as well. I'll go back to Professor Samuel Kaba Akoria. He was the lead neurosurgeon, but he's breaking it down so that we understand the antecedents, the history. He just talked about very early trephining, where holes were made in the skull to treat epilepsy, to let out demons or spirits, and to also manage tumors. So he's proceeding now to break it down. We have the other members of the team. We have an anesthesiologist. We have a clinical psychologist in the studio. And then we have another consultant neurosurgeon. Stick and stay. This is Joy 99.7 FM. Yes, Prof, go ahead.
So I apologize because I don't know why the internet keep
no
okay.
problem.
But then I try to put it in the two forms, where the one part, and extremely important, is where the anesthetist put the patient to keeps the patient awake. And it also has this form. I'm not going to dwell into that because I'm not the anesthesiologist. But even that, anesthesia came in the 1840. And before then, these awake surgeries were being done. Now, when it comes to the neurosurgeon part, is to have the ability to do brain stimulation and brain mapping. We have what we call brain mapping, and we have what we call the negative brain mapping. Now, if you look into Tree of Ghana, okay, and I acknowledge that in one of the videos I did, that Professor Mustafa did the first brain mapping, because from the anesthesia point of view and my conversation with people, and even from the same Kodebu, the where he kept the patient awake and giving something to read, and then he was able to do some level of surgery.
Exactly.
Right. Then came the world that, okay, for you poor guys in resource constrained countries, by then awake surgery had moved from the
Okay.
99.7 FM.
Unfortunately, we're having some challenges. Let me swing to Dr. Jerry Agudogo. If you can hear me, Dr. Agudogo, he's an anesthesiologist. Oh, my goodness. And he's online. Doc Agudogo, can you hear me, please? All right. Okay. We'll swing into the studio. Anne, you're with us. You are a principal clinical psychologist.
Yes, I am.
Your lead neurosurgeon was breaking it down, and I'm sure you and I appreciate the antecedents, okay? But one of the important things in the procedure was the area of brain mapping, right? Mapping specific areas of the brain to function, okay? And you had a big role to play in there alongside a neurophysicist, right? Can you just explain to my listeners what your role was in this brain mapping, and also making sure that the patient, in this case Sylvester, was awake and being specifically stimulated to allow you to assist in the brain mapping? What exactly was your role there?
Okay, so my role was to help in the stimulation of certain regions of the brain.
Right.
So we're working with the Wernicke's area of the brain. That's where the tumor was, around that area. It affected his Wernicke's area and a little bit of the Broca.
Right.
He had some issues with the Broca area, which has got to do with speech.
So he had speech issues.
He had some speech issues, and then the Wernicke's area, which is also got to do with understanding, comprehension, and also being able to reproduce speech.
Right.
So because of that, we had to ensure that these areas of the brain are being stimulated, so that the neurosurgeon will know that this area he's not supposed to touch, and that area he's supposed to touch. He's supposed to work on, and all that. Yes.
Right.
So with the recognizing, like showing the book to him, the book of pictures.
He was recognizing and naming animals.
The infratemporal cortex was being stimulated, that side. So he was able to name. It helps with recognition of objects.
Okay.
Yes.
So you're doing that
around the temporal lobe. All
right.
that is around
Let
the
me just
temporal
break it
lobe.
down slowly for my listeners. So you are giving the person stimulation, right?
Yes.
He's processing the visual material.
Yes.
He's recognizing the objects or the animals. He's naming them.
Yes.
Now that corresponds to activity in the brain, right?
Yes.
Which is now imaged properly for the neurosurgeon to see, right?
Yes.
And correspond to the areas he's touching, right?
Yes.
So you are mapping the areas of function and the areas that may be impacted when he starts to remove or work on the tumor.
Yeah.
So that's your role.
Yes.
Alongside the neurophysicist.
neurophysicist.
Right.
Yes.
And you're seeing all of these things on screens. The imaging is clear. There's 3D imaging, which also facilitated the process.
Yeah.
Okay, right. So when you ask him to physically manipulate, let's say, an instrument, he was playing the mouth organ, he was using the tambourine, at some point, speech, singing, and so on and so forth. In the same way, you were stimulating the brain, and then that allowed Prof. and Dr. Vuado to now map properly.
Yes.
Okay.
So the mouth organ, the playing of the musical instrument, and then the tambourine and all that was stimulating the angular gyra.
Okay.
That's the place that was affected, where the tumor is.
Right.
Certain places, yes. It helps with music.
Okay.
Being able to produce music and all that.
Okay.
Yes, processing. So it's got to do with attention, semantic memory, processing of information.
Right.
It's got to do with self-processing, emotional regulation, and all that. That's
Okay.
what the angular.
Great stuff. I'm sure.
So, yeah.
I'm sure my listeners understand. 25 minutes already past the hour of 2 on Joy 99.7 FM. We are looking at this interesting surgery that was conducted at the Greater Accra Regional Hospital. We've looked at the background, okay? We're not interested in challenging history. That's clear. But we have the specialized multidisciplinary team assembled on Joy 99.7 right now. Let me swing back to Professor Kaba Akoria, and then also go to his colleague in charge of anesthesiology at the Greater Accra Regional Hospital, Dr. Jerry Agodo. Let me go back to Prof. Prof, can you get back on track so I switch to Jerry? Okay. All right, so let's go to Dr. Agudogo. Doc, can you hear me?
Joy 99.7 FM.
Okay, it looks like we still have a challenge online. Hello? Okay, we still have a challenge with the team online. So coming back to you, Anne, in the studio, whilst we try and sort out these
All right.
Okay. Is that Jerry Agudogo?
Can you hear me, please?
Yes, I can hear you. Is this Prof.
This
Akoria?
Prof. Kaba.
Prof. Kaba. Okay. I see that you dropped the Akoria. Yeah. Should I drop it as well? I see you referred to as Prof. Kaba.
No. That's my father's name. That's a very Prof. Kaba Akoria.
Akoria. Okay. Please kindly proceed. So we've understood
But for many people,
we've understood the premise, right? Sylvester had a tumor. The location of the tumor and the, should I say, presentation that made it a good choice for this procedure. Can you just go through that again? Because you needed to keep him awake or conscious on a certain level so as not to, should I say, cause collateral damage whilst trying to remove the tumor. Can you explain that to our listeners?
All right. So let me just pick it up from there and explain that when you the left hemisphere, every human being, the brain is divided into the right and the left. The left controls the right and the right controls the left. And the left is the doctor. To level of tests like MRI, and they're trying to do what we call cartography. That's brain mapping. You might damage the person a lot. Now, I was telling you a story about Jenner who introduced brain mapping in 1909, right? And this is the first mapping in Ghana, without any doubt, was last year.
Okay, Dr. Agudogo, if you can hear me, let's just switch to you. You handled the patient's consciousness. Dr. Agudogo, can you hear me?
Yes.
All right, you're welcome, sir. So you had the duty of working on the patient's consciousness to facilitate the process. In the initial stages, of course, you put the patient out, then you wake him up sufficiently for the process to continue. Can you just explain that for our listeners?
Yeah, Mr. Dewar.
Yes, kindly proceed. I hope.
Yeah, maybe. Are you getting him?
Oh, okay. Prof is back. Okay, Prof, please continue then.
Yeah, let me see if I can really. I'm now on the phone and see if I can really get this done once and for all.
Okay.
So what I was trying to explain is that the human being brain is divided into two parts: the right and the left. The left is in charge of the right body, and the right is in charge of the left body, right?
Right. Yeah.
And the left is eloquent, is the most dominant. So if you got a patient with a tumor in the left, you got to be extremely careful, or else what you do would damage the patient. Now, Brodmann came out with the mapping in 1909. That's 114 years ago, approximately. And I was trying to emphasize the point that the first brain mapping was done in Ghana last year by my team in collaboration with Focus. Okay.
Right. Mm-hmm.
And when you're doing brain mapping, awake surgery, one of the principal things for a neurosurgeon is to be able to do brain stimulation and mapping. And this is the first difference between what was done previously and what we did. Now, even if you take the full text of what was done previously, they will completely outline to you that, look, the majority of the cases that were done, there was no brain mapping. Okay. So it essentially was to cut down the cost for anesthesia.
Right.
All right. And that was to make sure that with the anesthesia component, people don't go to ICU. You don't have to get central lines. Your hospital stay will be less. Infection rate could be less, which is all thanks to anesthesia. But when it comes to the neurosurgeon, what you need, the tools you need, the arsenal of tools for you to be able to do an international standard technology-guided awake surgery is that, one, you need to have the necessary tools like a good MRI, do cartography, what I call brain mapping. And I'll have to emphasize on this today. When Brodmann did his mapping, he found out that there were about 87 eloquent areas. Today, we are doing what we call connectomies. We're doing what we call connectomies. And connectomies, we found over 187 places, which we consider to be eloquent. So every part of the brain now becomes very eloquent. And that started in 2014 in the developed countries.
Right.
So this is what happens. The next thing we did was to use an ultrasound, and that is going to be the future of medicine for the developing countries. To be, when you're doing ultrasound, it's like live. You are live doing something. So we use the ultrasound together with what we call the neuronavigation to be able to target the tumor exactly where it is, do the resection without damaging the peripheral tissue, right? And then after that, we were now able to do the brain mapping itself and the brain cortex stimulation. That makes a huge difference in whatever has been done previously and what we did. With the stimulation, you are able to, if you watch the video again, you will see in a point where we ask the patient, can he identify? He said, I cannot identify. Now, if you don't stimulate to know whether there is activity or not, you grossly remove that. You will be happy, but the patient will never be able to identify anything anymore.
Right.
So we have a technology-guided procedure. Now, I'll read something to you and your listeners so that you understand. And this comes from what I was trying to explain earlier on. Teaching and sustainable implementing of awake surgery in resource-poor setting. This is the document that was brought up for discussion within the medical field, that this part of this happened in Kolebu. Yes, so some people decided that, okay, we're going to teach the poor people how to work within their limited resources and do awake surgery to cut down the cost of anesthesia.
Right.
Okay. And then the document continues. It tells you in page 3 that no cortical stimulator was available for mapping functional areas. In contrast, in high-income countries, mapping is almost always attempted in appropriate cases.
Right.
Are you with me, please?
I'm right with you. So the mapping and the
patients with that.
Yes. Okay, continue,
Yeah.
Prof.
No, I'm just reading a section for
Yes,
you
I'm
to
listening.
understand.
Yeah. Mm-hmm.
That even with negative mapping, okay, that is safe maximal resection of non-functional cortex, 13% of patients still develop worsening of post-operative neurological deficit, indicating that when you don't do the mapping, right, that is how many people you get to injure. When you do the mapping, it guarantees you better results. Now, we did not, and I emphasize that we did not have the mapping in those things. We did not have the neuronavigation in those things. We did not have the ultrasound in those things. We did not have the brain stimulation in those terms. So this is actually the first comprehensive, fully technology-guided awake surgery done from the neurosurgeon point of view.
Right. Prof, if I
and
may...
I want to credit...
Yeah, go ahead.
All the anesthesiologists who have done this before, and our lead surgeon, Dr. Mustafa, who attempted all this before we even were born.
Right.
Yeah.
Thank you for that, and I hope my listeners understand. It's about 14 or 2:35. We're going to proceed, but Prof, that is an important area, because I do recall that in the instance of the conjoined twins from 2021, there was a lot of awareness and spearheaded by, I believe, Star FM of the EIB group. And then government responded by taking up the full cost of the separation of those twins and bringing in the important critical equipment that you talk about now. And that is what was also used or harnessed in this surgery. Am I right, Prof?
Absolutely. In collaboration with, because the brain electrophysiologists and the brain mapping issue, we actually had a collaboration with the people from Focus. But the rest of this was from that equipment. Right. And fortunately, let me even make a point that Ghana College of Physicians and Surgeons have established the Faculty of Neurosurgery, and there will be many centers accredited for this. And this will include RAGE, maybe Cape Coast, the 37 of the UGMC,
right,
and Kumasi, Tamale. And I do believe that it would be nice all those places have this kind of equipment.
Right.
But it makes a whole lot of difference.
Okay. Before I swing to your colleagues, let me just quickly ask. Sadly, we lost one of those twins, and I do believe baby Elisha is still doing well. Can you confirm that after the separation of those twins, we lost one in the procedures, and the other one, I believe, was doing well. Can you just clarify that?
Yeah, the other one is doing extremely well. And as we give the press conference, there is still the need for some couple of surgeries to take place to close up some skin defects that we experienced. But technically, he's well.
Okay.
And as of today, as I talk to you, he is very well, and we still have some few steps to go.
Okay.
But thanks to them, a lot of things have changed within the arena of neurosurgery in the country.
Right.
Because with them, we've been able to do a lot of surgeries. I mean, thalamic tumors, deep-seated brain tumors. And I have to also make this very clear that when the conjoined twins came, the brain mapping issue came because that was the first time we intended to put it. So to introduce it, and then we spoke to the people in Focus who had the electrophysiologists, and then we had conferences with people in the US to start talking about brain mapping. Focus had a lot of experience in electrophysiology when it comes to spinal stimulation and all that, but it wasn't used in brain mapping until these twins came, and we decided that we wanted to put it into brain mapping. But unfortunately, its use was limited. But right then, we introduced it to do the first brain mapping in Ghana.
Okay, great stuff. You're still with us on Joy 99.7 FM. The program is Ultimate Health. Despite some technical challenges online, we have been speaking with Professor Samuel Kaba Akoria, lead neurosurgeon in this recent May 25th brain surgery that was done, conducted on a police sergeant, 39 years old. He had neuropsychiatric symptoms and presentation, right? It was found he had a tumor which had to be removed. And we've been explaining why this procedure was used, and we're going through so that we all understand. WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and shortly I will activate the phone lines so you can ask your questions. Let me move to the anesthetist, Dr. Jerry Agudogo. Doc, you're welcome again.
Yes, thank you. Am I on now?
Yes, I can hear you loud and clear.
Oh,
So,
good.
right.
Yes.
Okay, so you're a pivotal, in fact, a very salient part of this team. We know we put people out so that we can conduct these procedures without pain and many other complications. What's your critical role in this specific procedure that we've witnessed in Ghana?
Yes, thank you. And on behalf of myself and my team of Benjamin Amoa, Akosia Kota, and Dr. Valdez. Now, what we did was to ensure that when the patient wakes up, the patient will be fully awake, no residual effects of the drug that will interfere with the neurophysiological mapping, and the patient will be pain-free. So we did it in 2 phases. Initially, the patient was put to sleep. We gave some analgesia. We put the patient on TIVA, which is total intravenous anesthesia. And then we went ahead with the help of ultrasound, to do a skull, a regional block of the skull, so that by the time the patient woke up, he was well anesthetized. I mean, the analgesia was excellent, and he was without pain. Mind you, I'm sure Prof has already explained that the brain itself is not painful.
Right.
Of course, that's in a nutshell. But then there are other things we had to take care of to ensure that the patient's airway was patent, hemodynamically was stable, in short, to ensure a successful outcome. And then, most importantly, that at the end of it all, our patient will not lose any of those eloquent functions, such as speech, visual, and then motor functions.
Right. Thank you, Doc. So when you put the patient under, if I can use that term, that level of anesthesia allowed the processes for taking off what we call the fold or the scalp, right, to access the brain. So at that time, if I may, at that time, the skin and the bone, I mean, at that time, the patient is out, right?
Yes.
And then you change what you're doing with regard to his consciousness, with regard to his pain management, for us to have the second phase where we say the patient is awake and being stimulated by Anne and the others to facilitate the mapping of the brain areas.
Yes.
Okay.
That's right. Yes. Because we had to take care of the most painful parts of this procedure. Mm-hmm. So that's, as you said, the skin, underlying tissue, and the bone. And of course, the membrane covering the brain as well.
Right.
That's the dura. Yes.
Okay. So we noticed in the video that you're all communicating quite effectively. There's a lot going on. We also noticed that this was also being, should I say, telecast, and there were residents and students and other levels and cadres of professionals able to monitor this. I have promised the team that we'll do a second program where we look at the training and capacity building potential of this. But what I wanted to ask is that apart from the, should I say, mapping related additions and enhancements, did anything change for you? What was critically different for you in this procedure?
Well, it's the advancement in the drugs therapeutic available. So we got to use medications that we can easily titrate to get adequate sedation when we need it and to make the patient awake without any residual interference. We have better monitors so that we can hemodynamically monitor not only the pressure, but we could take care of things like invasive monitoring if necessary. Now, one of the most challenging aspects is the airway control because the patient's head is fixed.
Right.
And when the patient is awake, in case it develops any complication, an airway obstruction, and you really have to go in, you might have to rely on some other equipment. So things like video laryngoscopes, fiber optic laryngoscopes, intubating, LMA. So these are all devices, some subglottic devices.
Right. All of these were available and accessible for your team.
We had most of them.
Okay. Thank you very much. Let me just come to the other neurosurgeon, Dr. Emmanuel Yavuado. If you can hear me, sir, just confirm.
I can hear you.
Right. Now, Dr. Agudogo just mentioned the patient's head is clamped, and I saw all those. This is the Layla retractor and all those clamps and the Mayfield clamps and all those things. His head is stationary and his body is stationary to a large extent. Now, when you get feedback from Anne, the patient, and the team that is helping with the mapping, the brain mapping. So where, for example, Anne reports or the patient reports, I cannot see this, or this particular function is impaired or not happening. Does that mean you've damaged something? What can you explain that part? You're mapping, you've got the mapping, you can actually target what you're doing, but does that mean that there's no possibility of damage because of this mapping?
The mapping is precisely to prevent the possibility of damage. So, the moment we touch a structure, we try to look for feedback from the neuropsychologist. Okay?
Right.
And upon the feedback, then we'll decide to advance what we are doing or not, or retreat.
Right.
So this is the interesting aspect of it. Okay? That the constant feedback from the neuropsychologist and the patient is informing us whether to proceed or to retreat.
Right. So that minimizes collateral damage.
That is it. That minimizes the collateral damage.
Okay. If I may proceed also, Doc, we had this equipment, I believe, 2022. I'm not too sure about the dates, but we didn't have them before. Was the team, as a team, and indeed you, the neurosurgeons, it seems you must have been quite familiar with this, and after this separation of the conjoint twins, I understand you've done over 300, if not more, procedures using this equipment. Was the capacity there already? We knew that we've been doing, should I say, lesser ranges of this surgery, but with this new additional and enhanced technology, what was your experience and expertise with this?
The capacity was there when we were trained in different nations
right.
to come back together. Okay? Only that during the years we didn't practice it, the capacity was like frozen.
Okay.
With the acquisition of the new equipment, we had training, okay, with the companies that produce the equipment.
Right.
Some trainings were in person, some other trainings were online, okay, to begin to use this equipment. So this permits us to use the equipment and also to be able to train.
Okay, right.
To be able to train other colleagues when they have their new equipment.
Right. This is an important and significant and salient addition of capacity. And if you just joined us, it's about 48 minutes past the hour of 2 on Joy 99.7 FM. Every single person I've spoken to, every single specialized professional I've spoken to is a Ghanaian, is located here. I'm not sure about the rest, but I do, from my reading, understand Prof. Akoria has his training in Cuba, Spain, I think, and other places, but essentially they are all back here. We need to retain and build this capacity, and this is important. And then, of course, the addition and the governmental will to bring in this, I guess, in response to the conjoined twins, also opened up more possibilities. If you have any questions, concerns, Abeku, can I just switch to the WhatsApp screen and activate the phone lines very quickly? 0302216541. My listeners know typically I would have activated the phone lines earlier, but we have a lot of ground to cover, even though we have promised the team that we'll do 2 programs to look at the other areas. Okay, let me just quickly, and Prof. Akoria and the team, kindly bear with me whilst I read this out. This is Oye Nathania. Welcome me. Thanks. Okay. Next one, Abeku. Okay. Good afternoon, Norte. No, I can't see the rest. Much appreciated. What does this say? Okay. Right. We're waiting for a couple of more messages. So we have this capacity. Let me come back to Sylvester. Right. And this was an 8-hour surgery or procedure. Prof. Akoria, so I heard you assuring and reassuring Sylvester after the procedure, 8 hours. And then also I realized that you did a lot of prep and even a simulation before the actual procedure. He was shown the equipment, told what he would go through and so on and so forth. May I ask, currently, how is Sylvester doing and when was he discharged? Because my reading tells me that typically you reduce inpatient time, use of ICU, cost, and all that. And the patient, after about 6 weeks, should even be able to go back to work. What's the current status of Sylvester or Sergeant Sylvester Boachi?
All right, let me quickly say that he's home. We discharged him on Saturday, and that was like we did a surgery on a Tuesday and he was discharged on a Saturday. That's like 5 days later. And we actually could have discharged him earlier, but we just needed to make sure that everything is in order so that there wouldn't be any situation. Right from the surgery, he's been very well. We took him some few minutes to the ICU, from there to the HDU, which is then from there to the ward. We just stepped in quick, and he was perfect. And then he's back home. He's doing everything normal. There was a follow-up video where you could see him walking with Dr. Vado and the rest of the team. Wow. He's home. He's doing well. He's not complaining of the initial symptoms and signs that he had. And I would just want to add that one of the things we actually enjoyed in this particular surgery, as we talk about technology, had to do with projecting the whole procedure. At every given time, we had about 5 cameras projecting inside the theater and outside the theater for people who were not able to be inside the theater, students, nurses, anesthetists, to be able to follow everything that was going on. Wow. And this is also thanks to a conjoined separation. And for the first time, not in this particular procedure, but in Ghana, in our equipment list, for the first time, we've done it in other occasions. We inject what we call a spy agent. It's a tumor staining product that when you inject into the patient, it goes to stain only the tumor. So when you under the microscope, under fluorescent microscopic dissection, you see the tumor in a different color, and you see the normal brain in a different color. So it gives you a lot of precision. And then we also use what we call a 3D printed. So in this version, you can actually see the whole thing in 3D, up, down, side, any part. So it's been a lot of learning experience, and it's been a lot of encouragement for the team to have all this capacity, which did not exist barely even before the conjoined twins. And this made this surgery very, very unique, together with the ultrasound. But let me also recognize we have a Cuban specialist who is also a neurosurgeon with us. She's called Dr. Mariela Infante, who is a neurosurgeon, pediatric neurosurgeon with over 22 years of experience in pediatric neurosurgery.
Right.
And then Dr. Alejandro Sanz, who is also a Cuban with a lot of experience in anesthesia, working with us in the Rich Hospital. So besides the Ghanaian team, we had our colleagues from Cuba join us because they are in Ghana for the Cuban-Ghana mission. And then we had the Focus Orthopedic Hospital team also join us. So, but you are right. The other difference was that in other awake surgeries, as I read the title to you, was to come and teach us how to do, but this was purely Ghanaian-led together with our collaborators from Cuba, that we have to also recognize them. So,
Right.
Forward ever.
Right, forward ever. If you have any questions, concerns, the phone line is active, 030-221-6541. We're live on Facebook and YouTube. And despite some technical turbulence, we're getting into a good understanding and insight of the processes and procedures. But let me ask, if I may, Prof, you are the lead. This is a sergeant, a police sergeant. I read the history. He had been in Sawam Hospital prior to the movement for the surgery and many other things. But with the conjoined twins, the government bore the cost of the surgery, the procedure, bore the cost of the equipment and its installation and everything. So a lot has been, should I say, taken care of. How financially accessible is this? And how does the cost limit your ability to harness and apply this across board, even if within or restricted to Ridge or Greater Accra Regional Hospital?
All right. So let me start by saying that one of the things we as Ghanaians we need to understand, and is easily understandable by every Ghanaian, is that government cannot do it all. So people have their own out-of-pocket payment. But it would have been nice to have a health insurance system that covers everything. So where I was trained, you walk into the hospital, you get everything done, and you get out. Now, the various associations to, let's say, police service, they have their insurance system to take care of their people, military, Ghana Health Service, and everything. Now, here's the point. Most of the time, we get a lot of patients, and we have the equipment, but the equipment, you need some consumables. You need to feed the equipment because they are like kind of robotic equipment. So for the robot, you got to feed it some information. Now, sometimes the patients have to cover up those consumables that we will need. Some of them are not health insurance covered. Some of them could be. And then if it happens, it means the patient will have to acquire that. Or in this case, the police service will definitely reimburse him because we've been having that kind of agreement with them where they take care of their patients. So, and we as a government hospital, we don't go ahead to charge anyone. When you come in, our job, my job, and the team's job is to do the technical component. Then the Rich Hospital Administration, the finance division, does the financial component to look at how many days have you stayed in the hospital, what medicine do you need. Those that the hospital can provide, they provide. Those they cannot provide, you go across the street and you buy them yourself. Those that are covered by health insurance takes care of that. Those that are not covered by health insurance, then you got to pay for it. So if, let's say, hospital stay is covered by health insurance, well, you walk out. So, and one thing I need to emphasize that technology is very expensive. And as we move in that direction, we need to find a way of also covering health insurance for everyone so that people can access it.
Right. Okay. Right. I've grabbed a couple of extra minutes so that we'll go into a little extra time to establish a few things. Dede in Maryland is asking, what was the intensity of the clamp on the head not to let his movement affect his surgery? Right. I talked about the clamps and the arms and things that allow you to do so many things. She's asking about intensity. I don't know which of the neurosurgeons will take this.
All right, so let me take this.
All right.
In the practice of neurosurgery, we insert the clamp in strategic areas. Around the bone, the skull bone has some dimensions. You have the outer part, the middle layer, and then the inner part. In sectioning a plant, one of the things you take into consideration is to make sure that you don't penetrate into the brain. So you search for places that quite robust in their dimension, and at the same time, your clamp shouldn't interfere with the area you're going to work at. So, with that, you then clamp the patient to the extent that the patient cannot move the head. Now, we don't measure the intensity. That dimension itself is not being measured. What is being measured is to make sure that you don't go into the brain and to make sure that there is no movement.
Right. Okay. Makes it sound so simple. If you have any questions, concerns, I have a couple of minutes to spare. Let me come back to you, Anne, in this studio. So we've understood the role of the neuropsychologist or the clinical psychologist, the neurophysicist, and all that. But Prof mentioned a lot of work preparing the patient and the patient's family. Now, we know this was, filmed, right? It was used for training purposes. There were other cadres of health professionals who could see this. You were in the theater yourself. I do believe at some point, I think TV3 covered some parts of it. Was there any family member present? And did you have to go into getting them to understand and work with them as a psychologist as well to understand the process?
Yeah, so there was a family member who was present at the ward.
Okay.
So we brought both